Yes, good evening, one and all. On behalf of Rajkot Ophthalmic Society, I, Dr. Suketu Bhappal, as the Secretary of Rajkot Ophthalmic Society, would like to welcome you all to this first Mathur, Nagpal and Balda Oration 2021. For further details, I would like to hand over the stage to the President of ROS, Dr. Mukesh Porwal. Over to you, sir.
Thank you, Dr. Suketu. Good evening, everyone. Rajkot Ophthalmic Society is immensely pleased to bring you this first of the ROS MNB orations, named as a token of our respect and gratitude after the three doyens of ophthalmology in Gujarat, Dr. R.N. Mathur, Dr. P.N. Nagpal, and Dr. C.R. Balda. We are even more delighted to have two of these stalwarts joining us online today. And actually, Dr. Balda has been instrumental in making this oration a reality. This will be a much different webinar than the other ones, and a unique oration in which we give 1 full hour to learn from someone who has reached the pinnacle in his work, followed by two discussions of 15 minutes each on the subject with eminent panelists. You will all agree that there cannot be many better ophthalmologists and orators than the nationally and internationally eminent cataract surgeon, Dr. Abhay Vasavda. Thank you all for taking the time and joining in on this weekend. And now, to introduce the first of our three greats, Dr. R.N. Mathur, I would like to invite my good friend and versatile phaco-refractive surgeon, Dr. Harshal Balda from Rajkot, to introduce Dr. R.N. Mathur.
Thank you. Respected seniors, friends, ladies and gentlemen, it is an honor for me to introduce Dr. R.N. Mathur. Dr. Rajendranath Mathur was born on 8 October 1930. He completed his ophthalmic studies as a master's in ophthalmology at Jaipur in 1959. He went on to serve at the Christian Medical College, Vellore, for 8 years. He established the ophthalmology department at the MP Shah Medical College, Jamnagar in 1967 as its first head of department. He was the head of department of MNB Institute of Ophthalmology, the Western Regional Institute of Ophthalmology at the BJ Medical College, Ahmedabad, from 1978 till his retirement in 1989. From thereafter, he was honorary consultant at the Retina Foundation, Ahmedabad. He gracefully left this world for his rightly deserved heavenly abode on 7th November 1990. He was a teacher of teachers. He dedicated his life to ophthalmology, his students, and above all to his patients. He will be much remembered by all those who were touched by him. According to my father, Dr. C.R. Balda, he is one of the two persons who made a better human being out of him. The other person being Dr. P.N. Nagpal, Dr. Mathur's friend and colleague. And I'm sure there are many present here who would echo the same sentiment. Today, we honor the stalwart of ophthalmology and humanity through this oration. Thank you.
I now invite Dr. Sanjay Gadre, our very own comprehensive ophthalmologist of many, many years and great experience, to introduce the one and only Dr. P.N. Nagpal.
Thank you. Can you hear me, Mukesh?
Yes, yes, sir.
Oh, thank you very much for giving me this opportunity to introduce Dr. Nagpal. And fellowship to Germany to work with Dr. Meyer Schweckerath. After he returned, can you hear me?
Yes, sir.
After he returned, he established the Retina Foundation in Ahmedabad in 1975. And after that, he almost problems all over the country. At the same time, he had in the foundation, he actually taught a large number of ophthalmologists how to do retinal surgery, and his fellowship he is a man who is multi-talented, a great orator, academician par excellence, a very skillful surgeon, a doyen in ophthalmology, a teacher of teachers. And besides that, he has a great organizing abilities. He organized conferences all over the country when he was part of the AIOC's scientific committee chairman he was. And then in Ahmedabad, especially when he, under the aegis of Ahmedabad Academy of Ophthalmology, he conducted very successful conferences. He is a very well sort of speaker, and he is a very well known international sort of eminent personality, especially known for his contribution to retina. I would say he was one time one of the most popular Indian ophthalmologists world over. And I would say that he, at a particular period in time, he was an Indian ambassador in ophthalmology in the World Forum. I'm happy and privileged to welcome Dr. Nagpal in this virtual oration. Sorry. Thank you.
Thank you, sir. I now invite Dr. Sandeep Visani, our phaco-refractive surgeon of Rajkot, to introduce Dr. C.R. Balda.
Thank you, Dr. Powar. Good evening, all. It is an immense honor to introduce Dr. C.R. Balda, sir. Actually, Dr. Chunila Rauji Balda, he was born in Doraji in 1942. Actually, he is the inspiration behind this oration. He was the first student of the MP Shah Medical College, Jamnagar, under the teachership of Dr. R.N. Mathur and Dr. P.N. Nagpal. He had humble beginnings and he progressed step by step. At present, he is the senior most ophthalmologist in Rajkot, with more than 50 years of private practice. But he is always in tune with the current ophthalmology. He is a father figure of ROS and GOS too, as well as Rajkot IMA. Actually, we are grateful for him for providing the corpus fund for this annual oration. Thank you, sir.
Thank you, Dr. Visani. I now would request Dr. Nagpal sir to say a few words to start off this oration. Sir, please.
You might find me a little slow in starting. That's because of the Parkinsonism that happens.
You can speak.
Rajkot.
Yes.
Rajkot, they've told what all is there at Rajkot. One of them is no doubt Dr. Gadre himself is very popular figure in the region. He is very kind to me. I thank him very much. This area belongs to Dr. Balda and his son working hard for ophthalmology. There was a person who was visiting Saurashtra, Gondal particularly, where the king of Gondal, who was a doctor, physician, as well as surgeon from Edinburgh, and his teacher came to visit him at the invitation of the kingdom. He was traveling through, but unfortunately, he succumbed to some infection before he could go back to. On the day he died, the kingdom, which was controlled by the surgeon, physician, Bhagwat Singh Ji Maharaj, who was the king of that place. The shops were closed, for 2 days, and special arrangements were made to allow the public to see. And then later on, he prepared a memento-like thing on the ground. He was nobody else but Argyle Robertson. Argyle Robertson, son's pupil. You have known that. But you can see the person who is a pupil of Bhagwat Singh Ji. So this area is known for the ophthalmic history. Unfortunately, present corporations do not respect the sentiments and they don't clean the area. But I would suggest that on behalf of the society, let's contribute funds and make it look better.
Really, sir.
This honor, which has been given to my mentor, Dr. R.N. Mathur, and also to Dr. Balda, who was our first student. Before that, there was nobody else. There used to be one Dr. Gursahani, if I remember the name correctly. I would like to express my special thanks to Arup Chakravarti, who has come. No, he has not come. He's being projected. We have to change our language in due course. Let's start.
Yes, sir. Thank you so much. It is nice to hear you after a long time. I would invite some comments from our Dr. C.R. Balda to start off this oration, just before we start off this oration. Balda,
Hello, good evening everybody, and most warm welcome to all the participants of this first MNB oration. My special thanks to Dr. Abhay Vesauda, Dr. Chi Shun Fek, and Dr. Arup Chakravarti for sparing their valuable time to participate in this first hour adventure, MNB oration. So please accept my heartfelt thanks. And I would like to say a few words about MNB oration. Whatever I am today is because of the two great stalwarts of the ophthalmology, late Professor Dr. R.N. Mathur and living legend Dr. P.N. Nagpal. Within just first month, Dr. Nagpal allowed me to do cataract surgery independently. That is the beginning of my career. And then they showed me the pathway to serve the people and to serve the ophthalmic sciences. And the way pathway they have showed, I am trying to follow that pathway. And this is the first step to pay regards and respect to these great stalwarts with whom I had a chance to work for 3 to 5 years. So without taking much of your time, I thank you all the participants, all the people who have participated in this MNB oration. Thank you once again. Over to Dr. Porwal.
thank you, sir, for those nice words. Now, on behalf of Dr. R.N. Mathur, who is no more, we would like to have a few words from his nephew, Mr. Alok Mathur.
Good evening, friends. Good evening, ladies and gentlemen. My name is Alok Mathur. I'm Dr. R.N. Mathur's nephew. I'm glad and thankful to Rajkot Ophthalmic Society for keeping my uncle, late Dr. R.N. Mathur, in its memories for all these years.
Can you be a bit louder, Alok?
Yeah. Is it okay now?
Yeah, better. Go ahead.
I'm glad and thankful to Rajkot Ophthalmic Society for keeping my uncle, late Dr. R.N. Mathur, in its memories for all these years and paying him tribute during this academic session today. It has exactly been 31 years now since he passed away in November 1990. Many of you, I'm sure, must have not seen or met with him, as you had probably not even started your medical career then, but still you all chose to contribute in remembering him is a well-earned thought, which is rare if not impossible. Thank you very much. I would like to say a few words about him, which probably are not known. Dr. Mathur was a legend who remained in the memories of those who knew him even distantly. It was not only his dedication for his profession or his skills as an apt doctor and teacher, but his persona which attracted everyone towards him. His humble yet disciplined approach, willingness to help everyone, working as a team, and humanitarian attitude won all hearts. As you would all agree, he was as renowned a doctor as he was an illustrious teacher. Moreover, he was considered as an outstanding ophthalmologist, an articulate speaker, a dynamic team leader, and a humble humanitarian. Besides being a professional, he was a family man too. He was a doted son, a reliable brother, respected father, and above all, a great human being. Not many of you would perhaps know that he was equally a good sports person. He remained the captain of winning hockey team of SMS Medical College Jaipur during his stay there. He was a fine badminton and tennis player too, and he enjoyed traveling to new places. If he had not passed away so early in his career, he would have definitely served the medical fraternity for years to come. I would like to pay my homage to him and take this opportunity to pay my respect and regards to other legends of ophthalmology, Dr. Nagpal, Dr. Balda, Dr. Vachrajani, and all others who were dear friends of my uncle, whom he treated like brothers, and they have all helped take ophthalmology standards to new height and bring Gujarat ophthalmology to international repute and standards. I wish them a long, healthy, and blessed life. Thank you very much.
Thank you, Mr. Mathur. That was so nice. I now invite Dr. Kamlesh Kalaria, our phaco refractive surgeon, to introduce our other panelists, the guest speakers on the subject.
Good evening and welcome to ROS MNB Oration. I would like to introduce our two guests in very brief. Dr. Professor Chi Soon Pek is a senior consultant of ocular inflammation in immunology department at the Singapore National Eye Center. He has
Little bit louder, please.
He is a master in complex cataract and UATs at the Singapore National Eye Center. He has been awarded the SNEC professorship in clinical education in ophthalmology, a teaching legend in cataract surgery, and a prolific academician, author, clinician, and researcher with numerous publications on her name. We welcome her warmly for giving her precious time on this evening. She will be discussing some final points with Dr. Vasavda. Next one, Dr. Arup Chakravarti is a very prolific cataract surgeon and glaucoma surgeon. He works at Chakravarti Eye Care Center, Trivandrum. He is running that institute. He has been passionate teacher for many years. He has been holding various instruction courses at national and international levels. He has been editor proceedings of AI conferences, which have taken the conferences to archiving at a higher level. He has many books, publications on cataract surgery on his name. He will be taking soon as the president of Kerala State Ophthalmological Society next day. We congratulate for him. I mean, he and Dr. Chi Soon Pek will be holding discussion after the oration. Thank you.
Thank you, Dr. Kalaria. I would like to ask Dr. Ketan Bavishi, our phaco refractive surgeon of many years of experience, to introduce our orator tonight, Dr. Vasavda.
Good evening, everyone. Today we have with us the legendary Dr. Abhay Vasavda of Gujarat and world ophthalmology. He does not need any introduction, but I will try my best to briefly encapsulate his journey and work. Born in Rajkot, studied at Baroda, and did his FRCS from England. After returning, he started his practice at Ahmedabad, and later on in 1991, as a director, he started Iladevi Cataract and IOL Research Center at Ahmedabad. He is a supreme master and pioneer of cataract removal with phacoemulsification in India. He is a superlative teacher with his voice and the art of live surgery. At present, he is the president of APACRS. Sir is a star speaker and the course instructor of many national and international conferences like ASCRS, ECRS, AAO, APSCRS, AIOS, and many more. He has published various papers on FEPO technique like step-by-step chop in situ, inside-out delineation, multi-level chop. He has been awarded with numerous honors and titles. He has trained more than 150 fellows and observers at his operation theater. Non-ophthalmic hobbies are yoga, meditation, trekking, cricket, and swimming. It shows his physical fitness. Few years back, he did the trek up to the Mount Everest base camp successfully. So now I present Dr. Vasavada sir for his oration. The topic is Quest for the Excellence. Over to Dr. Vasavada sir.
Unmute. Can you unmute me?
Sir, you are unmute. You can start.
You are audible, sir.
Just hold on. I just want to remove this. Where is the cursor here? Can you remove the site, please? Just hold on for just. I thank Rajkot Ophthalmic Society for giving me this opportunity, but also congratulate them for such a noble endeavor. I wish there's such a respect and the feeling towards our respected teachers, and the Legion was done much more earlier by larger society. So I think Rajkot Society has done a commendable attempt and endeavor to initiate such an event, and I hope others learn from this. I do have a financial interest that I receive research grant support from Alcon, but it's no relevance. And I'm going to sort of go through the lessons that I've learned, and from that you can pick up whatever pearls you think you want to. I acknowledge all the educators like Arup Chakravarti, Sunfei Chi, and many more from our state, India, and globe, who have educated so many of us, and I learned a lot from these experts, the colleagues, and very importantly, the trainees, the fellows that we had over the years. And I cannot not mention the patients who were very kind to us to allow us to do what we wanted in the best interest and best intent we have. And I think I would agree to Dr. Balda's comment when he said that he changed, 2% changed his life. I'd never had a pleasure of working under Professor late R.N. Mathur, but I had a privilege of interacting with him on numerous occasions. And also he was a friend of my father. So, but for Sir, Prannath Nagpal Sir, whatever I say, I can spend an hour of talking about him and not the other topics. But the fact is that I have not come across any other individual apart from my father who really have influenced and contributed to many, many ophthalmologists, but surely I'm one of them. So I'm so blessed to see that I was known to him, and he really took special pains to influence my career and my profession. So thank you very much, sir, for all that you've done for me and all of us here. I also want to mention late Dr. Daljeet Singh, who really influenced the cataract surgery in India and also in Europe, because he was the one and pioneer in IOL implantation, and he was a master craftsman. And I picked up quite a few tips in my early career. So I really thank late Dr. Daljeet Singh and his family who's pursuing that equally well. So the lessons learned are many, but I've sort of simplified lessons I learned as a clinician, lessons I learned as a surgeon where I performed the surgery and technicalities about it, and also some interest as a researcher, a curiosity. So I'm going to deal with that now in a kind of a segment way. And first thing I would say is that for my junior colleagues who are just joined this path and wonderful profession here, that remember, we need to be very helpful and empathetic or sympathetic to our patients and also all the treating personnels in the system. So that you never forget about it. And remember, history taking, as we used to call, listen to the patients and the accompanying close ones with the patient. Give enough chair time and understand them, because we all are very eager to look into the slit lamp or a retina and find out the disease of our interest. But first of all, first is first, listen to them very well and have an approach not looking at the disease of your interest like cataract or an eye, but the person who is sitting in front of you and also the family who has come along with it. So in other words, get interested and find out about his health, general well-being about himself, and how he approaches the life and how he treats the world. And then for my junior colleague, the first question I asked to the patient is, what do you think, how is the world treating you and how you think is the world? Not the eye, not the thing, not the health. And so I want to understand that and have that thing. And it's sad to know that the human aspects of medical practice, be it ophthalmology or any other thing, is really degrading, and more attention is now being diverted or paid to the other aspects of medical practice, commercialization, and with all the due respect, I call it sometimes Americanization, which I mean is we forget the basic human aspects of medical practice. So that's one thing. And second thing is that we are not supposed to have answers of everything. Health and disease are such issues. So accept our limitation as a clinician and always ask for second opinion from an expert or a senior person if you think, because whole intent is to really help the patient who has come to you to seek advice in the full trust in you, and therefore sort of appropriately behave that way, and don't sit on a patient whom you think others can treat better or can advise you in difficult things. And that means managing these conditions with appropriate experts, subspecialists of various types, and you know that very well. So I think that's always been there, but it is more important not only for scientific purpose, but also morally and legally, and quite obviously ethically. So remember, one person is a good warrior and a fighter, but we really need to formulate a team consisting of various supporting staff, doctors, optometrists, and so on. So formulate a team of whatever you can. And it's quite interesting that many years ago, when I was a student in medicine and ophthalmology, comprehensive ophthalmologists were the only one. They would treat everything, the refraction, the cataract, the retina, and whatever they could. Then the era of specialty and Professor Dr. Nagpal, for example, started the retinal specialty in India, along with Dr. Badrinath and Nam Perumal and late person whose name I forget from Delhi. But now we are back to that. So we are having another comprehensive team. So from one person, a single person doing comprehensive ophthalmology, as a team now, either as a one roof or otherwise, we are doing that. So it's good to know that we are back in the circle again. But remember, when a patient sits in front of the slit lamp, you would check him, advise him, and treat him like you would have done yourself to be treated. When I joined medical school, late Professor Dean Joseph told me that, son, when you're very excited to hang a stethoscope on your neck, but remember, when you put a stethoscope, the other person at the other end is also a person like you, and treat him and do whatever you need to do as like that. So that's one. But this is what Dr. Nagpal taught me, that respect your colleague and support your colleague when you see a patient being treated either surgically or non-surgically by your colleague, and don't sort of give any bad mouthing or comment which will be injurious to the colleague and also the ophthalmologist society in general. So thank you, Dr. Nagpal. Now, technically speaking, this is something we all are too busy doing this. And I spent many years for that. And I realized that you don't need to be extraordinarily brilliant craftsman, but you need to be thinking louder or a bigger picture. And first thing is that I took time to understand that, to recognize that there's a need to refine the performance and keep doing it in a predictable fashion and getting better every time in immediate as well as the long-term outcome. And you must engrave in your mind that. And if you do that, you will automatically take an appropriate actions. Our goal as a practitioner, wherever you are, is to make the patient happy as you would like when you go as a patient. And the cataract surgery can be used as a means or a tool as a refractive surgery, but that's not the end point. You can use this surgery to perform and manage so that you improve the vision quality and raise the vision before and raise the expectation. But ultimate goal is really to make the patient happy and not perform refractive surgery alone. So remember that. And I took a long time. And therefore, you're able to now make for you, customize, having understood that process. And that really made me think that preoperative workup is something we need to pay attention. And I took, it's only for last 10, 12 years that I'm doing as I'm doing today. The importance and the value of the time you spend in a workup and have a system. And first thing is that you need to have a dedicated time slot. Do not mix the preoperative evaluation of the eye and the patient and the family during the routine OPD outpatients clinic. Call them again, having seen in a routine OPD, on a separate time slot so that you have nothing else but to do that, and have a dedicated team doing that. The consultant, the optometrist, the technician, the counselor, every time, these are the people who will do the same machine every time they become experts. So that's very important, and particularly ocular surface, the imaging technologies like OCTs and various other things, you need to have an access. Even if you don't possess it, make sure that you do that whenever you have to do that. And at the end, counsel not only the patient, but the dear ones, and make them understand the disease, make them aware the possible intervention, particularly the negative or side effects of these, and then you decide after understanding them, their personality and so on, and do the customization. I think I was fortunate to be one of them, one of the persons who started ophthalmic anesthetists in our nation. I can easily say that. And I picked up from Dr. Gimbel when I visited him in 1990, and he had an ophthalmic anesthetist. I never heard that term. And there is a Society of Ophthalmic Anesthetists in early 90s. So we started that, and I not regret. And now I see most of us have the devoted anesthetist team with us. This part, I think, is well understood, and all of us, without exception, are doing the right way now, after some of us struggled in our initial years to understand this wonderful technique of phacoemulsification. So I think all these steps are done very well. But I want to concentrate on three aspects of these surgical technicalities. And one is the posterior capsule surgery, which can change the fate of the eye. And for me, I do it in a congenital cataract. Whenever there's a PCR, I attempt that. In a traumatic cataract, even in an intact capsule, I do that. And very limited way in a very, very advanced chronic angle closure glaucoma and a severe pseudoexfoliation with some manifested late complication in the fellow eye. I do the posterior capsule surgery, and what I mean is that I capture the IOL optic, having put the three-piece IOL in the sulcus and then capturing to anterior capsular axis and posterior capsular axis. And this is my routine in a pediatric cataract, but you need to do that for better stability and also to avoid vitrectomy in that group. This is an example of a PCR being converted into a continuous rhexis, not necessarily a circular round rhexis. It doesn't have to be that, depending upon the rhexis tail, the tail. I could manage, fortunately, which I cannot do every time. But if you do that, you can continue with them. This is a multifocal lens in the eye, stabilized well with these rhexis performance. And this is a traumatic cataract. No anterior capsule in 1/3 of the anterior capsule, compromised bag. Posterior capsule is intact. And still, I am trying to perform posterior capsular rhexis here. And the reason is that although I can place the haptics in the bag in this direction, it auto-rotates and sometimes it becomes asymmetrical and stability is an issue. So what I do then is to capture the optic through that posterior capsular rhexis where the haptics remains underneath the anterior capsule. And even if it remains outside, the optic is behind the posterior capsular rhexis. It is the same eye where this is the posterior capsular rhexis in front of the optic. The optic is behind, and this is the incomplete anterior capsular rhexis, which is fused here because of the trauma. So that's posterior capsular rhexis. But this is something very interesting, and this is something which we are recently doing it. The problem with the very advanced angle closure glaucoma, almost like an absolute glaucoma when they're present to us, there is these issues, technical issues with forward rotation of body, and malignant glaucoma occurs after the cataract surgery and IOL implantation. And this is one such an eye where everything is pushed forward in spite of a very good surgery and in the bag implantation. The IOL is in the bag, but the whole bag with the zonules, because the zonules are pushed forward rotation of the body, and zonules are weak. So in that case, we suggest, and we are learning this, where routinely we perform ciliary sulcus haptics and capturing the optic to ACCC and PCCC, and therefore we are able to produce a good restoration of the anterior segment. And this is that eye where the optic is behind the capsule and there's a decent space, and the ciliary body, which was here, has been rotated, restored. So that's one thing, and that can be applied very, very selectively in an advanced pseudoexfoliation condition, not every time. So this is one such example. So I think that we are doing good phaco, all of us, but if we can now also master and excel in performing surgery on the posterior capsule, it is very rewarding in these although rare or uncommon, but it's something which is very important. Dr. Balda mentioned about the hydrodelineation, and I just want to address very quickly that this is a very good technique. Generally speaking, many people use this, but inadvertently, the fluid can go subcapsularly when you try to produce delineation here. And if the capsule is fragile, as it is in the posterior capsule, you rupture it. So with the help of our team, we performed inside-out delineation where we create a space and then inject, and therefore the fluid doesn't go in the subcapsular plane. And this is an example no hydrodissection, no subcapsular hydrodissection is performed. A trench is created, and then in the wall of the trench, an angled cannula initiates and demarcates the central nucleus. The posterior polar cataract, and I recognize the contribution of Dr. Robert Osher here, and he really is the pioneer and taught me and many others. But these are the poles that I would like to display here for your notice. I find very useful, and something that I will come to this in a minute later on. But these are the things that I learned over the years, and CHOP in situ also Dr. Balda mentioned. This is then, we published it in 96, and this was recognized or renamed as a vertical CHOP later on by Dr. Pfeiffer. So this is something which we found very useful, and whether the cataract is soft or hard, it's possible to perform this, and particularly useful in a small rexis or a small pupil where you don't have to do any blind procedure. Everything you do is under vision. So that's something I would like to mention. And same thing in a very leathery advanced cataract, you can repeat your CHOP procedure, whatever it is, horizontal CHOP, vertical CHOP, whatever, at different planes, so that you don't need to stress the zonules, because what we are interested is to segment the bottom plate, fragment and create a total division of the bottom plate, which is very difficult to produce working at the anterior plane. So you do that, rebury the phacoprobe nearer to the bottom plate, and then you can perform that. And that you can do it with the horizontal or a direct CHOP as well. Take the phacoprobe out once again, work it toward the center portion, and bring that crack once again. So that will reduce the lateral separating movements, the stress to the bag, and you can produce a total division, which should be the aim in such cataracts. And also the final endpoint of these divisions, we learn in a hard way, should be as small fragments as possible. Larger fragments are not easy to handle. So that's something, but this is the technique, or this is a step of cortical aspiration that I want to pay a little attention. It's been taken as a rut. I didn't pay much attention of the cortex because it comes off anyway. Whatever the technique you have, you are able to remove all the cataract. But if we pay attention and go in the principle of performing step by step, whether you step by step division or fragment removal or a cortex removal, you will find a difference. And what this is, and Dr. Viraj named it as a POPS technique, means positioning the aspiration port in the right plane, occluding it, and taking that port posteriorly and then swiping. And I'll show you that very briefly. This is the positioning of the aspiration port under the anterior cortex, under the anterior capsule, and the PICS animation will illustrate that I positioned it. And then I put my foot on the pedal and initiate some vacuum, 100, 150, which will occlude, which will suck the anterior cortex and will remove the anterior cortex off the anterior capsule. So that's something which is the next step. And then we need to take that occluded aspiration port posteriorly toward the capsule a little bit so that it really detaches completely. So you're ready to now detach it of the anterior capsule. And that's the first thing. And that's important because the anterior epithelium is lining the anterior cortex, not on the posterior cortex. So they have a firm desmosomes and villi, which sometimes leads right pull, and this is the right orientation. So that will completely detach the anterior cortex of the anterior capsule, and then swiping movement from the fornices. The cortex is still lying in the fornix with the epithelial cells, what Dr. Apple called the E cells, which can potentially produce PCO. So these are the steps, and then finally put your fat pedals down, so preset vacuum is achieved, and you're able to remove the entire cortex, right? So that's something, thank you, Viraj. And this is Dr. Samaresh, our colleague, showing how, what happens in this animation when you do a radial pull, which I did for years. When you just pull it, sometimes, not all the time, if the adhesions are stronger in the fornices, some cortical fibers harboring these epithelial cells are left behind. But if you do that now in a manner Potts way, with swiping and going through the step, you're more likely to remove the cortex completely. So that's something I thought would be very interesting, and we find it different. And we believe that our PCO rate has been influenced once we adopt this Potts technique. We obviously need to understand the different viscoelastic, and Steve Arshinoff taught us all these properties and rheological characters of these different OVDs, but this is one adaptive viscoelastic Helon 5 being injected in this child's eye with a very elastic capsule, and with the micro instrumentation and small incision created, we are able to fashion the rexes of our size. So OVDs, use it judiciously, but the technology, the technique and technology combination is something which is really very important. You may have a great skill, and most of us have good skill, but you need to also gel that with the appropriate technology, which sometimes is prohibitively expensive, and that's a tragedy. But whatever you can, keep the technology updated, and I must give credit to White Star Technology, because they are the ones who gave the concept of using the energy from continuous mode to different interrupted modes, and you can have a burst mode or a pulse mode. These all are displayed on the user screen, but the real thing is the interrupted phaco energy, using it as for a small period like 5 milliseconds. And then the torsional or ellipsoidal, but torsional more, change the way the lens fragments are removed. There is no repulsion or minimal repulsion, and therefore you don't need to be very aggressive on the aspiration force of the vacuum in the on the Bosch and Lomb and others Venturi system, or you don't need a very high aspiration flow rate as in peristaltic system. You can achieve the same effect like a high flow rate using low aspiration and vacuum because of that no repulsion, and have an appropriate fluidics. If you have an IOP monitor, it's even better, but appropriate fluidics. And most of the machines have good fluidics in these tanks. But just want to draw your attention and notice that low parameters, we discovered that gives a better, clearer cornea and less inflammation on immediate time. At the end of a month, everything is fine because of the nature's the reserve and the healing capacity, but you can achieve a fair amount of speed and performance, but achieve a clearer cornea and disturb the IOP to lesser extent, as you can see on these two diagrams. So we measured that real time, and we found once again and supported what we found on a clinical study that lower IOP and lower flow rate is one good option. And that's now from gravity-based system, I called a passive fluidics. We have moved to a semi-passive or semi-active system, and Dr. Agarwal Amar, my friend, had some idea about it, but not very clear on the fish pump that he used many years ago. But then the companies took up that and they developed a semi-passive or semi-active system injecting air, but it had issues of uncontrolled IOP and fluctuation. But then came the IOP sensing system, and that what the company called active fluidic is the technologically assisted active fluidics really working very well. Whatever that is, whatever the machine you have, doesn't matter. What is important is to keep in mind that when you remove the fragments or divided lens material, and I think you should divide first and then start removing it. That's a better thing. But whatever, when you remove the fragment, keep this endothelium and the cornea and the plane of the emulsification. And then if you work it at the iris plane, it is much better than working anterior plane and doing it faster. You will be tempted to work here in anterior plane if you're very high flow rate because you are threatening the capsule. So low flow rate, but work away from the endothelium posterior plane. That's what something is more important. And OCT really hammers in our mind, as you can see on the right-hand side. Fragments will keep touching or come in the vicinity. And in the video, you won't realize that. So when you remove the fragment, it goes so fast and you're very happy. But remember this OCT, you don't want to be away from, you don't want to do that. So that's one. But this is something is very close to my heart now for last 10 years or so. And I struggle. And I really discussed with eminent persons like Dr. Kelman himself, one-to-one, and many others. And I realized that we need to change. And then I must now thank Dr. Manish Nagpal, Olay Banker, and Steve Charles, because we put up a course with Steve Charles on the subject for cataract surgeons. And pars plana approach is something I would urge you to just listen to it and consider it whenever you're ready to do it. And this is an example of a lot of lens material still there and the posterior capsule rupture, and you know how you feel. Now, first thing is to inject viscoelastic before you exit the instrument and stain the vitreous, identify the prolapse of the vitreous, but then is the key moment. We all would actually would perform a limbal vitrectomy because we already have a two paracentesis created. Do not go through the main incision, never, because you will compromise the chamber stability. Keep the valve okay, and then go through that, and then do the limbal, which works okay. But if you do the same procedure with irrigation here and vitrectomy instead of here only 3 millimeter or 3.5 millimeter away from the limbus, it's the same thing. It's your mindset. So this video will illustrate how effectively the vitreous from in the anterior chamber is then drained into the vitractor by just 3.5 millimeter. I mean, you don't need this sophisticated trocar. You can have a lens knife, peritomy, conjunctival, lens knife, and then see the vitreous being drained without any turbulence and affecting the posterior capsule or anything else. And now you're ready to remove the lens material. You don't need a lens scaffold or IOL scaffold or whatever. You don't need any of these, no lavage, no levitation, nothing, because there is no vitreous, and with the appropriate parameter, you can remove these lens fragments very easily. So that's what it is there. And Samaresh, my colleague, once again illustrated so beautifully how the pars plana vitrectomy works so efficiently, adequate vitrectomy without compromising on that, versus limbal, which I've done for years. You can understand there's a drag, there's a pull on the vitreous body because you're working top down, and that invariably enlarges. And how familiar it is. We started with a small tear, ends up in a very large tear, and it's so disappointing for us. So that's the reason. Samaresh, thank you so much. Now, limbal approach, therefore, is very familiar, and that's the only thing I saw until I met these individuals I mentioned. And then, therefore, it was a routine thing. But the problem is that, as Steve Charles and Manish and Olay taught me, that our aim of vitrectomy is not to salvage the sinking lens material anyhow by Vactis or by lavaging or levitation, nothing. No, our aim is to reduce the intraoperative vitreoretinal retraction for the consequences of it and produce an adequate vitrectomy and hopefully put the lens in the bag, which is our always thing for cataract surgery. And that's where the pars plana approach shines out. It produces a minimal retraction to the vitreous face, retinal vitreous face, and a thorough vitrectomy is possible. So, although it is unfamiliar territory for a cataract surgeon, we think it is the forte of Mukesh, Porwal, and others. Sanjay Gadre would agree that you can do as a cataract surgeon as well. It may appear intimidating for those who are not familiar. And mind you, the most important, you don't need any other machine. Same machine you have, you can do a decent job of doing that, just changing the approach from limbo to pars plana. And this is once again Samresh beautifully showing on a high-speed photography what is the turbulence. The retractor is from the limbo approach, and you can see the whole thing. And at the end, the tear enlarges invariably. Now, if you see that same thing, the vitrectomy is now through the pars plana. Same machine, same irrigation through the limbal approach, no turbulence or minimal turbulence, and the tear will remain as it is, generally speaking, at the end. So remember these animations of summation and keep in mind what you want to do it one day if you're not already doing it. But this is the thing, didn't want to talk about it, but Mukesh Porwal asked me to say something about it. And this is something like Sunfek Chi here is very close to me. And I have 50% or more than 50% of my patients I do now for last few years are done with this flex or femtosecond cataract surgery. And I'm able to perform with more control and prediction. And I realized that it eases the steps of the cataract surgery. It's really predictable and safer, not only in the beginning person, but also an experienced surgeon in routine, as well as the complicated or challenging scenarios. So I think this is one of the challenging scenario. And we found that technique of creating cushions after cushions by delineation reduce our rupture rate very favorably. And we also published that in a shallow chamber, and we Indians have shallower eyes than many Caucasian eyes, which goes undiagnosed or undetected. And we found that the corneal thickness and inflammation was favorable with the flex when we did a randomized study on the first day and the first week. However, at the end of a month, all corneas are the same. So that is why we are still not terribly motivated to change on, in addition to the expenses, and it's expenses which is the main reason. But even in an immediate scenario, if the corneal thickness is favoring, why not to do it? And this is not common in white cataract. Typically, you will have some micro bridges left, but those bridges are easy to remove and produce the rexes of this kind because the intralenticular pressure is released by the flex machine. So I would just say that the flex machine has a promise and has sufficient evidence to support in a challenging cases. The evidence in the routine cataract is actually not favoring flex, but saying that it's the same as the phaco. So why to spend so much of money? And that's a real issue, and I agree to that. That the money the companies really demand from us for not only the initial expense of buying it, but maintaining it, the PI, the interface that is needed, the maintenance cost is prohibitive. And I hope these companies change one day their mindset, but I doubt. So this is the flex. I personally find it and enjoy that, and I find it useful even at the practice point of view, so not only the scientific speaking, but it is the co-management that I have discovered much more. We were as I say, the retinal surgeons I mentioned were helping me, the corneal surgeries, the corneal colleagues were helping me. But if you can have under one roof, or at least an arrangement where you can have your corneal diseases, the retinal issues and complications of cataract surgery managed with joining hand, is something we should consider, and it's a necessity. And this is one example, whether you have loose zonules or no zonules whatsoever, you need to have a retinal colleague, moral and scientific support for that. And if you want to achieve capsular bag reposition, you need to take the Gore-Tex suture now, which is not FDA approved for ophthalmic use, but I, along with many others, Dr. Rosenthal, Dr. Sioni, Dr. Late, Ellen Crandall, showed us how to do this. And this is something that is not degradable. and this will be there forever. Only thing is that if you are in a subconjunctival space and if you're not covered it with the flap, they are notorious for producing inflammatory granulomas on the subconjunctival, but otherwise they are there forever. So if you have a dropped IOL or no zonules to begin with, you have an option, as I just mentioned, sutured IOLs with, I recommend Gore-Tex or iris close, as the late Dr. Dalit Singh worst IOL or whatever IOL you want to use, iris close. It's wonderful, this option. But my preference now with intrascleral fixation, and credit goes to Gaber Shariat to begin with, but Amar, my very dear friend, made it so simplified and popular worldwide, the glued IOL he calls it. It's really very good. But now, having done glued IOL, I'm switching to Yamani in many cases, still continuing glued, but Yamani is something is my preference at the moment because there is an appeal, and I'll show you that appeal. But whatever that is, that dispenses away the need for flap creation or dissection of the conjunctiva, and you can do with a closed chamber technique using 30 gauge thin-walled needle. Mind you, the routine 30 gauge doesn't work. You have to use 27. And use these lenses, and there are companies now which make these lenses very friendly to railroad or to needle through this 30 gauge cannula and use the appropriate micro instrumentation and bring it out. This is very logical, and rather than going the reverse way as we have done with the Gabor's and Amber's technique, which is very good and it's repeatable, is more predictable probably. But this is something which is appealing, and this concept of creating a flange or a mushroom has been utilized in many different ways of different IOLs now. That very concept, and then that you don't need to suture this now. So that Yamani really has given a new dimension to that, I would say, and I will value Sunfaik's and Arup's opinion on this, because this is something that is increasing. Why we need to know this? Because the late decentered IOLs, I have done my own IOLs in early 90s, and I'm getting few of them back with late decenter. And there is an epidemic in the USA, as the late Alan Crandall was telling me 2-3 years ago. These IOLs keep coming back with decenter or drop. So we need to now address these ideas, and Amar was well ahead of us in that. And this is the Yamani, you saw the picture, the surgery. Very briefly, we had a luxury now of the toric component of the IOL with monofocal and trifocal is the way to go now rather than a conventional multifocal. And there are various companies giving this trifocals and all work very well, trifocal lens. And I just illustrate the new the concept of trifocal and extended depth focus. This is an ophthalmologist, very active ophthalmologist in one of the states, and he has a good share of multifocal practice himself, and he uses progressive glasses, and he himself was keen on trifocal, and he was driving at night in his city, and he wanted to do that. So we thought he was suitable optically, no angle, SCAFA, and all the other thing. We did tell him that you may need adequate light and you may see halos. And he said, yes, I know, I have many patients with that. And we did this trifocal toric lens because he has astigmatism. Bilaterally, he rang me a week later that I started doing all this, my practice, and he is very comfortable. The ophthalmologist, a very active ophthalmologist. And he really had a halos, and he still has it, but it's not a bothersome. And because of his motivation, he is fine. Now, this is a different scenario, and I want to highlight a newer technology IOLs and extended depth of focus IOLs. And there are many options we have, and all these lenses work very well. Some of the lenses have more visual phenomena, dysphotopsia, than others, but principally, this is a very good innovation technology. And this is an example of a very active person driving at night and I had to give up driving because of the cataracts, and he was myopic, so he had a good vision for near, and this is how it was. So we had to take care of his activities. He was checking on the computer and going back to city through country road because he was quite affluent and he was staying in a very nice big house. So he had to drive quite a bit. So we did discuss with him, and this is the key, as I alluded, preoperative discussion after understanding him and telling him the negative more than what this lens is. Because the company will tell you that this lens will give you this, that, this. It never happens in reality most of the time. So always bring out, even if it is a remote possibility of using the glasses for all distances, if it is off-target ametropia. All these lenses, what the company says works well only and only when you achieve a targeted refraction, which Dr. Holliday told me that it doesn't happen every time. The centration doesn't happen perfect, the backside disparity, the target ametropia, but more importantly, defocus astigmatism, which you develop and induce, and which you already have. So be careful, give all the negatives before you tell them. And this lens, which is a kind of an extended depth vision, the company will give whatever name it gives, but this is one example of these group of lenses. I find this one gives less or minimal dysphotopsia and achieves a good added intermediate vision, surely, and some degree of reading vision, in addition to a very, very good distance vision. So these kind of lenses are really changing well, and that particular patient was very good. So keep in mind different options, remain updated on the not only the machine part of it or investigative machines like OCTs and others, but also on the IOL frontier, and you decide whatever which appeals you. But this is something very dear to me and Dr. Samresh and very other our team, and he produced a good video which won an award. But keep in mind yourself, if my back will, when one day will have an autopsy, you will have a unique finding of a phacosurgeon working for many, many years, and all the permanent changes which you are irreversible. So pay attention to that ergonomics of yourself, your posture, and also the patient, and make him comfortable so that you can perform well. So I think take care of your posture, take care of yourself. Be conscious of the damage you inflict when you operate, but also importantly, when you see 20, 30, 40 patients on a slit lamp where you bend every time whole your day. So start taking care, which I neglected myself. I'm trying to catch up now, but probably it's late. But so take care of ergonomics of yourself and fitness. But this is very dear to me. So I just want to spend a couple of minutes. There is a question, should we put an implant in children with less than 2 years? Because the evidence in the literature for a long time was saying, no, it's not very safe. And that was correct. So we took this issue and we published in American Journal of Ophthalmology of 2018, a 5 years follow-up of a randomized aphakia versus pseudophakia in children under 2 years of age. And I don't want to go into any detail, but sufficient to say that it is quite safe. The complications we noticed was comparable in aphakia as well as pseudophakia, except that the synechia to the IOL, because there is no IOL in aphakia, was more. And probably we may be inducing a little bit of more inflammation, but in the long run, the safety profile is identical. But there is a catch here and a caveat, and that is that all this we found because we had to have a meticulous criteria that the IOL had to be in the bag, had to have a particular Rex's configuration and a platform. So if you cannot achieve that safe environment, either you do not put the lens in the bag or do something else, or at least I still recommend that if you're not involved in the pediatric cataract surgery and took many years, abandon the IOL and let other persons do it later on. In a small children, particularly under 6 months of age. That's what I learned painfully in a hard way, having produced many complications. And then we also realized that vitrectomy had become a part of the cataract surgery in the pediatric cataracts, non-traumatic cataracts, congenital and development. And can we avoid that? And that we addressed that issue in a randomized fashion, again, publishing in JCRS, and found that the capturing these lenses without performing vitrectomy, 3-piece IOL, where the haptics were in the bag, but the optic was behind the posterior rexus, versus standard in the bag with the vitrectomy, were comparable. That capture demands a surgical skill in a patient, but it's doable. Keep in mind. And finally, we come to the clinicians, and I'm very happy there are many clinicians who are very, very curious. So the clinical research is nothing but addressing your curiosity. And if you just record your observation methodically, that is a clinical research. You don't need any sophisticated courses or any field that you can't do clinical research because you are in a small town or thing. Remember, all these techniques and things we enjoy now from our predecessors were done in a small places without any sophisticated imaging technology. So address your curiosity, but take that observation in a very methodical way. You are in a clinical research, you are on the path, and then you will develop your path well. So finally, you want to raise the bar from wherever you are, and I'm trying to raise the bar. I'm conscious of doing that every day, even today, and for next 10 years, I hope, and I'm going to do that. And continuously keep in mind, but remember, do not compromise the quality which you're set in examination, in your advice, in your ethical quality, the moral, and whatever else, and develop that raise in your clinical competence, surgical technicalities and performance, and keep it up. I'm finding it very challenging, and that's the energy that you will gain, additional energy, if you start doing that. And I'm sure many of you are setting example already, and I see that when I see around. But no shortcuts, no compromises. And if you can, use a better product, avoid as much as you can, and be realistic about it. Not every time, and everybody can do that, but disposable or better quality. But keep in mind, reduce the shortcuts as much as you can. So finally, the bottom line is, whatever we are doing, the patients are at our heart of whatever you strategize or whatever you do. And we all know that. So whatever I say, I don't want to say that I've given any new information to all of you. I'm sure many of you are wiser than me and better than me, but I thought for people, junior colleagues and across would be at least of interest. So finally, I want to thank, and I thank my one family, which is Raghudeep I family in Ahmedabad and Jaipur, and also Ila Devi Cataract Research Center to allow me to do what we are. And I cannot thank enough my wife, Hina, and all the family who supported me all throughout and gave me a little pleasures now with these grandchildren. So I owe them a lot, these families, and without team efforts, these success or whatever you're doing it's very hard to come by. It's practically not possible, in my opinion. So when I look back now, I'm really have a tremendous feeling of satisfaction of myself, my teamwork, and more importantly, I'm so fortunate to have worked and learned from people like Dr. Balda, late Dr. Mathur, Dr. P.N. Nagpal, sir, and many, many national, my local Ahmedabad friends, the state friends, the national friends. Arup is an example, and international friends that I had the opportunity to work and interact and learn many aspects of ophthalmology in the life. So I have a tremendous feeling of satisfaction, and thank you all that very much for that. And I'm struggling to do this, but I hope very much that I leave behind a legacy for my colleagues who are going to join or already have joined this path of developing a curiosity, of a habit, developing a habit of sharing your skill, your knowledge with your other colleagues and the team members, and have this desire of growing with each other in a team, but also as a society. And Rajkot Ophthalmic Society today has shown this example of by initiating this endeavor that they've done. And finally, of being human. And I can't be near to the stalwarts on whose name this oration is, but try to be as human as you can. And we have many examples of late Dr. Doshi, Dr. Advaryu, the living Dr. Kishore Asnani, and many others who have done such a humane work. Imagine 15,000 surgeries in a very methodical, scientific way that my friend Dr. Kishore Asnani does it in an area of India which deserves. And when I went there, people were picking up the wheat grains from the farms and dissecting that wheat grains from the cows' potties to eat. This is the poverty, and this is where the need was. And he addressed that. So hats off to all these people who have been showing exemplary humane behavior. So finally, thank you, Rajkot Ophthalmic Society, for initiating such an respectful event to our deserving colleagues and legions, but also giving me the opportunity in this your initial phase. But I promise, and even if you don't like it, I might come to the last oration of the 10th last oration. And if you give the chance, maybe I'll talk to the members again. So thank you all very much for your patient hearing. Thank you.
Thank you so much, sir. It was really an oration worth listening to. It brought up so many points in a very systematic way, both academic and non-academic points. And I'm really grateful that you took the time out to compile all those and tell us one by one whatever you've gone through all these years, probably 35 or 40 years in practice. So we can see the gist of it in this 1 hour of talk. And you've stuck to your time very well. So we have time for discussion. I would invite now Professor Chi Soon Fek to start the discussion, the first part of it, with Dr. Abhay Vasarda. Dr. Chi Soon Fek has done tremendous amount of work in cataract and refractive surgery, uveitis, and complex cataracts. So I think she is the right person to discuss certain finer points with Dr. Vasarda.
Give some more pulse, Soon Fek. I'm really looking forward to the pulse because I've learned so much from you all along. Please do that.
You're so humble, Abe. So I really want to congratulate you on a wonderful talk, for sharing with us your pearls of wisdom learned over a lifetime in your career. And I also want to thank the Rajkot Ophthalmic Society for the honor of being a panelist for speaking to you, Abe. So I agree with many things that you have taught us tonight. And I want to say that, when you spoke about showing respect and support to your colleagues, this is something that reminds me of Professor Arthur Lim. Even, this is something that I learned from him. We always need to respect and support our colleagues. And coming to more pertinent things surgically, I always admire the way you handle the posterior capsule And I agree with the applications that you showed us. And I just have a question for you. After listening to one of your talks on how you place the IOL in the sulcus in a patient with a very shallow anterior chamber, crowded anterior chamber, and then you do an optic capture through the anterior capsule and posterior capsule. I just wonder, you know, in such eye, usually the white to white is not that big either in these crowded anterior chambers. Have you actually done any UBM studies to look at where the haptics lie? Do they over time chafe the iris or the ciliary body and cause inflammation?
Yeah, I think this is a very valid thing. And I must say that I've never done in a very kind of a nanophthalmic eye or microphthalmic eye. I've done about 10 plus such eyes where the angle closure glaucoma either was neglected, became chronic and neglected. And then when we do the IOL in the bag, few times I ended up in malignant glaucoma and one or two eyes were lost because whatever we do vitrectomy, and it didn't work then. And I believe it's because of the loose zonules. They either primarily were loose zonules or become loose once that whole diaphragm remains like that. So I've done it, and I've done UBM, and I've done, and we are ready to sort of write up on this. We have pre and post and down the line UBM, and if the limbal diameter is not very small, or it's not a micro anterior segment, it works very well. I've never done it when the white to white is less than 9 millimeter. So I really don't know, and I would be reluctant to do that, as you brought it out very correctly. But otherwise, because there is a lot of only the haptics genu actually remains in the ciliary, so the rest of the thing there, and the ciliary processes are restored to some extent. It has worked so far, but performing this bi-capture, as some people say, that it's not easy all the time. So 2 patients I had to abandon in the process. But
right.
It has worked so far in this selected inclusion criteria-wise.
Okay, thank you for that. You know, I think that in these eyes also, it's important, at least in my hands, I like to insert a capsular tension ring. You know, so I think it does kind of pull the bag taut and back to the anatomical position. And I don't know whether that helps to reduce the risk of malignant glaucoma post-operatively, but that's something that I do quite routinely in these crowded anterior chambers. Do you have any comments?
Yeah, I think I will keep in mind it makes sense. It makes sense to keep at least the bag posterior part of it stretched. Maybe it cannot go wrong, number one, and it can have some beneficial effect in eyes. But if the eyes are very long standing with really very forwardly rotated ciliary body, and that's where UBM, you brought it out, and we have a very high-tech 2 UBM. When we do that and we concentrate on a location of the ciliary processes, if they're very forward, they're unlikely to work. The rings, but otherwise I think it's a very good thing, and I think I'll keep in mind in the moderate
Thank
cases.
you. The other thing I wanted to bring up is that, you know, when we teach residents, whenever there's a small PCR, and we always teach that we should try to round it off, and then if you can, at the end, when you put the lens in the sulcus, ultimately you want to do an optic capture. But I always caution them that if your capsular axis is not perfectly centered, by doing an optic capture, you are actually decentering the IOL, firstly. And secondly, I always think of what happens to the haptics in a 3-piece IOL. Because as I do uveitis, many of these patients get referred to my clinic having prolonged post-op inflammation, query, infective cause. But very often the UBM shows that the haptics actually chaffing the iris or the ciliary body. So I would say that if you can't have a perfectly well-centered capsular axis, or you can't position the IOL in such a way where in a particular axis it is centered such that the haptics will not be chaffing one side more than the other, I would avoid an optic capture. Any comments?
No, I think I absolutely agree with you, and I'm so happy that you brought it out. With the time I had, I didn't address all that. But say if there are 10 PCRs, it's only in 2 or 3 actually that I'm able to have that ideal central nice rexes which I can capture or keep it there. In 7, I do not do that. So I think the point is, and I think those who are listening, keep that what Sunfek said this. Do not be kind of fixed up in capture principles every time. Look at where is that rexis, how strong it is. Quite often, in addition to centration, there will be some little direction or notches or angle. They are not really truly circular. And that can split and extend that when you try to implant the lens. So be careful in that capture. But still, I think I would recommend to perform rexis. It will give a stable bag. Even if you're not using that opening for additional stability of the eye, that's a good idea to convert it. Will keep the vitreous at bay and will stabilize the bag. Yeah.
Okay. I enjoyed your discussion on, just the simple concepts of how we clean up cortex from the capsular bag. And what I always bear in mind is that after we occlude, get hold of that cortex and we pull it posteriorly, very many times we just pull it radially. And so I had one student who just radially stripped the cortex, and he did 12 strippings because it was 12 clock hours. And so I told him as he stripped, he should gather the cortex so that there was enough to occlude the pot of the INA. And as he gathered for a few clock hours and he was able to hold on to that, he was able to strip like 3 clock hours at one go. And actually in 4 stripping episodes, he cleared 100% of the cortex. So what I do in addition to just, occluding, I try to gather as much as I can around a few clock hours so that it will make it more efficient. And secondly, the thing which I noticed quite recently, other than stripping radially, we should do tangential stripping to lessen the stress on the zonules, especially when you're weak zonules in elderly patients with advanced cataracts. But also, one thing I've been doing is actually when I strip, I pull the INA tip into the bag deeper. Many of my students, they are so afraid of the posterior capsule that they pull it out of the bag. And when we do that, I find that we leave little fibers on the posterior capsule that we actually have to go down and polish manually, which makes it a bit more challenging for a beginner. So what I've been doing is actually after gathering the cortex, we strip and we pull it into the bag. And in that way, I find that we leave less fibers. And the other thing that I do before I put in the viscoelastic to inflate the capsular bag to inject in the lens is to actually flush the posterior capsule. Sometimes I can spend, 30 seconds trying to polish the posterior capsule because of a small capsular plug there from posterior subcapsular cataract, and it does not come out. But when I use a 30 gauge cannula with BSS and I flush it against the posterior capsule, when I allow the chamber to collapse a little so it comes a little forward, not to be too excessive, just enough, it actually flushes off all these little fibers, which I've been trying to get off for the last 20 seconds. And this can be far more effective and can really be more efficient. So something I would like to share with you.
Thank you so much. This is a very useful tip. Very nice. Thank you.
Yeah. So just flushing of the cortex. And, sometimes we always think we have to pull, we have to aspirate. So the other way of getting rid of something is to flush, which is to push out the fluid.
Yeah.
There's one comment that I don't fully agree with. Okay, Abe? You talked helpfully about past planar approach to vitreous management in the presence of a posterior capsule rent. And I really admire how you came up with this. And I do practice this in every case that I have a capsule rupture. But you made a comment that, that our L scaffold is not really that useful. For me, I think that I use IOL scaffold a lot to save me from a difficult situation. I use the IOL scaffold to protect the posterior capsule when I have fluid misdirection and the posterior capsule is coming up. I use it when I have a small posterior capsule rupture and I place it either in the sulcus or in the anterior chamber so that I can phaco the nuclear fragments which are trapped in the anterior chamber by viscoat. And that prevents the nuclear fragment from falling. And this is after clearing vitreous. Just last week when I was trying to remove Somring's ring in our subluxation, and I found that, it's so hard, it's so calcified, it's so difficult to remove it. And there's no vitreous in that space. And if we have the infusion coming from the anterior chamber, it will just push the Somring's ring posteriorly. And the problem when we phaco, we have so many fragments to still remove, is that the fragment will drop through into the vitreous cavity. And so what I did in the case of a Somring ring was I just inserted the 3-piece IOL into the anterior chamber. Under viscoelastic, I put the Somring's ring on top, just like I would have done for a nuclear fragment. And then I phacoed on top of it, after having done vitrectomy, and then I did my Yamani fixation. So I used the IOL scaffold for really very, very many things, when I have a difficult situation facing me. I don't know whether you like the IOL scaffold.
No, I think I have used, just to say that I've used it. But if we do the vitrectomy well, I find that the key then would be why the lens fragments drop, because the vitreous is wrapped around, and the moment you remove the vitreous, it sinks with the irrigation fluid turbulence. So ideal would be to go irrigation from the pars plana as well, but that's okay, we don't need to do that. So if we have a low IOP and 20 IOP or 20 centimeter or 30 centimeter bottle height with low aspiration, because if aspiration flow rate in a peristaltic will attract the vitreous from the posterior to the tear. So say I use 14 cc flow rate or 12 cc, which is the lowest you can go, 20 IOP in the machine I have, but sufficient energy, more energy. It is not going to ripple. Well, 7 or 8 of the time I'm able to do it. And even if it drops, I'll ask my retinal colleagues to handle it either same time or later on. But what I don't want is that scaffold, I believe, is only for a particular part of the anatomy. What we are interested when we do the vitrectomy and then subsequent removal is the vitreoretinal interface. And the traction or acute insult still would occur with the fold. So the scaffold is not going to reduce the chance of that. And that is the priority. And I really got convinced after doing courses with Steve Charles. And I think the scaffold is a good thing for us as the cataract surgeon. We can see that fragment is still there, but we don't realize many times, and not every time it happens, but scaffold is not going to reduce significantly that aspect of traction which we induce otherwise. But anyway, I take your point and I'll keep in mind, and I will certainly do that. There is an appeal, and I know many surgeons use it very successfully as you showed it.
Yeah, so I just clarify that what I do is I do the vitrectomy first.
Yes.
And when there's no longer any vitreous, the IOL is put there in order to kind of block off the pupil so that the fragments do not fall from the anterior chamber into the posterior segment because of the defect in the posterior capsule. So it's separate from vitrectomy.
That you said is correct. Most of the surgeons I see in the videos and otherwise, they straight away put this scaffold when actually there is a vitreous already in the anterior chamber. So if this is a vitreous strand, the scaffold goes like that through the vitreous, and that's little. So if you run a good vitrectomy, which you always do that, I think that's a good option. I agree.
Okay. So I have used Flex, as you mentioned, and I really enjoy Flex. In fact, in private patients, I tell them all that when I explain the procedure, I just put flex in it. So they don't know that they have an option not to choose flex. Because I really think that it does give a better outcome. At least I'm sure that there is a consistent size of the capsule rexes, that my effective lens position is going to be consistent. I can optimize my A constant and hit the refractive target. And of course, I use it in a lot of the challenging cataracts that I have to handle, and find it especially useful for subluxated cataracts. Because it, with the catalyst that I use, it can actually scan the interior capsule so that it can center it on the lens bag, which I will not be able to do as effectively if I'm just doing it manually, because from the scanning, it can predict where the center is. Like you, I've also been drifting more and more. In fact, it's now 100% to a Yamani technique. And very often I find that the patients who have lens subluxations are patients who often rub their eyes, and in their history, they will tell you that, I was having a shower and I rubbed my eyes and then suddenly I went blurred. And the other thing that I've been noticing, which I think is responsible for the epidemic of lens decentrations that we see across the globe, my own gut feeling is that it's related to obstructive sleep apnea. And, obstructive sleep apnea patients have floppy eyelids, and when they puff in their sleep, due to the obstructed airway, basically, if we were to blow a balloon 100 times, over, we would really feel that our eyes are popping. So I do believe that there are movements that happen, all right, within the eye, the lens. And we see that also when the patient starts to snore when you're doing phaco, all right, the posterior capsule comes forward. So I do think that all these movements over a patient's years, all right, of his lifetime actually do weaken those zonules. And very often, when I'm doing the lens fixation, the patient will start to snore. Okay, and so what I've been doing to these patients that, when I examine them, I just check the lids, they're so floppy. The next thing I do is I just refer them to our sleep clinic to get the appropriate treatment. And many of them are actually pretty symptomatic. So I think, at least in my part of the world, it's said that 40% of men have obstructive sleep apnea in Singapore, and 30% of women have it. So I've been diagnosing quite a number of women, but definitely more in men. And I've been seeing a peculiar type of lens decentration in these cases that I have to fix. And the cases that I see may either be complete zonular dehiscence, right? The zonules give way, but we also now seeing a different type of lens decentration where the posterior capsule is ripped and the zonules are still intact. I don't know whether you're seeing that in your part of the world.
Yes.
Yeah, so I'm currently collating my data. I think I've just over 40 cases that I've personally been fixing. And probably the earliest case, because I've got a whole archive of all my videos, probably since 2015 or 2016, I started to notice such cases. And I've been looking at the types of lenses that are associated with this particular type of lens decentration. And many of these are in square-edged lenses. So I actually think that the square-edged lens actually, with the posterior capsule fibrosis over time, may actually allow that square rough edge of the PCLL to actually cut the posterior capsule. And because it cuts it in a circular fashion, it actually scrolls back with the tension. So we see a scrolled edge of that ripped posterior capsule. You want to make some comments?
No, I think that what you said is correct, I think. And this is a very interesting area for people like us who are doing more and more and seeing this. And there are many diseases or many pathology, I think, in down the line will be revealed or we'll discover that. But I think we can go on and on such an interesting topic. But I really thank you so much.
Yes, ma'am. That was very interesting to correlate the obstructive sleep apnea with the posterior capsular rupture in the late postoperative period. Thank you very much for discussing certain really very fine points with Dr. Vasavada. Unfortunately, we are running out of time. I would like to move on to Dr. Arup Chakrabarti to take over the next phase of discussion with Dr. Vasavada.
Good evening, everybody, and thank you, Rajkot Ophthalmic Society and Mukesh, for giving me this honor to be present in this important program. And listening to Dr. Abhay is always a pleasure. Right from my student post-residency days, I have learned from him the various pearls sitting in the audience. And subsequently, I got an opportunity to sit by his side in panel discussions and courses. And it was a wonderful talk, Dr. Abhay, that you gave us. Okay. And we have learned not only the pearls of surgery, but towards the end of my association with him, as it matured, as it grew in a number of years, I learned a lot of lessons in life, pearls in how to conduct a particular presentation, how to handle question and answer sessions. So thank you, Dr. Abhay, for teaching the ophthalmologists all over the world the way you have been teaching. As regards your presentation, of course, it was beautiful, and there are a few points that I would like to make. You advocate posterior capsulorhexis, I think, in one patient who had a traumatic cataract with an anterior capsular tear, and patients with angle closure glaucoma. So these are the patients who are more prone for postoperative pseudophakic CME. What has been your experience with dealing with CME whenever you have done a primary posterior capsulorhexis in this kind of situations and in other situations?
I think for the traumatic, most of the trauma cataracts where I did PCCC and intact capsule were younger individuals, either children or sort of young adults. So I have not come across CME in that. From that angle, but there are some other issues because of the trauma and the surgery. But CMA would occur if you disrupt the anterior vitreous phase. And if I disrupt the anterior vitreous phase, which I have quite often, I perform antivitrectomy and then take care of the CME by putting these drops, non-steroidal drops, and then monitor them. But your concern and your question is absolutely valid.
Do you put
for the angle closure glaucomas, these eyes are very end stage of the chronic angle closure process. So they already have a very poor vision, and this procedure would avoid the malignant glaucoma or would reduce the chance of developing malignant glaucoma, but nothing more than that. All the other issues will remain even with this technique. So maybe they have, but CME, then that case is not as important because they don't have much vision anyway.
Yeah.
But what your point is correct, it's gone. And Dr. Galland, as you would know, published those reports. And if you disrupt the anterior vitreous phase, CMA rate goes up. So there is a cache here. Correct.
So you don't alter your postoperative therapy in terms of duration of NSAIDs and steroids when you have opened up the posterior capsule?
No. Because I look for triamcinolone staining at the end.
Okay.
Or so if I'm not, I will not change anything.
Okay. So the second question pertains to your concepts on management of posterior capsular rent with the vitreous disturbance. Let us see a situation where particularly a surgeon who has operated for a couple of decades has a PC rent in a very uncooperative patient. And there is not much time for us to go through the pars plana. And in that kind of situation, I think the bilimbal anterior vitrectomy still has a very important role to play. So what I would suggest that a surgeon should be familiar with both the approaches, the pars plana approach as well as the bilimbal approach of anterior vitrectomy. And depending upon the given situation, say, for example, if in a training institute where you get a PC rent, a resident, a fellow gets it, or a young junior consultant gets it, there's ample time, patient is cooperative to open up, the pars plana and do a pars plana anterior vitrectomy. But in other situations, I think where you have to finish off the case in time, at the same time, give good results to the patients without violating the surgical principles, I think limbal vitrectomy still has a good role to play. What I think we often forget is we don't adopt the proper technique of anterior vitrectomy. Many of us start performing anterior vitrectomy from the anterior approach, from a plane above that is anterior to the PC dent. As Samaresh has very clearly shown, so ideally one should start performing the vitrectomy just behind the PC dent to sever the stalk of the vitreous bridge which connects the anterior vitreous, prolapsed vitreous, and the vitreous in the posterior segment. In that situation, I am sure one can avoid enlarging the posterior capsular end that has happened and can avoid aggravating vitreous disturbance. That is what
I think, Arup, you have a very good point, and I agree with you. I don't want to convey that everybody should do pars plana vitrectomy moment you rupture the capsule. Continue doing whatever you're doing, but avoid drag on the vitreous by sponge and scissors, and no dry vitrectomy. And then gradually learn this pars plana, because it's doable by cataract surgeon. All of us can do. If you can do cataract surgery, you can do this one. But do not be dogmatic about it, and do whatever is the best in the interest. And I totally agree. The technicality that you address via how to do limbal vitrectomy, going through that, is absolutely correct. So thank you. Yeah, no, I think don't get the impression by those who are listening that the others is useless. No, the other is as good as. There is a subtle difference, and you want to achieve that one day, but continue what you're doing and pay attention to what Arup said. Go in behind the posterior tear to start with. That was a very good pearl.
What I thought is the surgeon should be adept with both the approaches.
Absolutely.
And depending upon the case, he should adopt the particular approach.
Very true.
Regarding the situation as to how to manage the residual nucleus of the vitreous has been removed, about IOL scaffold, it works very well in the hands of surgeons who are adept with alternate methods of IOL fixation, Yamane's technique and scleral fixation. But for, I think, a surgeon who is still in his learning curve, if you ask him to employ the IOL scaffold technique, he is not very sure about the integrity of the capsular bag and ultimately what happens to the intraocular lens that is implanted. So I think the take-home message should be, if the surgeon knows how to manage a lens which does not have an associated adequate capsular support, he or she should go for the IOL scaffold technique. Otherwise, he has to look for alternative means of managing this kind of situation. What I do is I use a visco-shield strategy where I use an adequate amount of a dispersive OVD, viscoat, nothing financial here, over the PC dent. And I've been able to remove big chunks of very hard nucleus just by using this approach, by repeatedly using the scaffold technique, where I just put the visco-shield technique, not the scaffold, visco-shield, which is used to plug the posterior capsule. So I think that has worked very well in my hands and some of the people that I am in touch with.
Absolutely correct. So I agree, totally agree. I think, we need to have various options and skill up our hands and use in the right case.
And another thing you're mentioning about IOL fixation, I mean, did you refer to patients where it was a 10 of Prolene suture fixated intraocular lens that were dislocating in the long period of time, or 9 of Prolene? Because today I've switched over to Gore-Tex, and in fact, I think I have learned it from you. The use of Gore-Tex, you're one of the first to start it in India. So today, whenever I do a scleral fixation, I don't use Prolene, I just use Gore-Tex. And I mean, maybe last 4 or 5 years, I have seen followed up these patients, and they've done pretty well. And since they do not biodegrade, I think over a long period of time, these lenses also should stay very stable.
Yeah, I think it won't degrade, as I see. I have about 10 years follow-up, but it's a good material, not degradable. But only problem with Gore-Tex is it's very difficult to handle. The needles are useless. And if they are exposed in the subconjunctival tissue, they are inflammatory. You will find a little locus thing. And I've done about 7 or 8 by now, sort of trim that knot which pops up, So we need to pay attention when you do this under the flap. But I think intrascleral has an appeal, and makes sense to me. And that Amar really gets the credit for this. Glued IOL is a very good technique, and continue doing it. Yamani is a little bit a different approach. To me, it's more appeal, as Sulfek said. Whatever that is, intrascleral and transscleral with sutures or iris claw, all of this work well. The way you're trained, wherever you're trained, you will do that, and that's fine.
I think Mukesh, these are the questions that I wanted to ask Dr. Abhay to clarify based on his talk. Thank you very much.
Thank you very much.
I just want to say, Mukesh, one line.
Yes.
If you have to name 1, 2, or 3 Indian faculty in the international faculty with the respect and the popularity, Arup will be in one of these 3. I see that, and he is climbing the ladder so well. So we are very proud of you, Arup.
Thank you, sir.
Yes, he has conducted FACO Pathshalas all over India and in his instruction courses all over the world, I think.
Yes, correct.
So definitely he is.
His video bouquet is his signature.
Yes. And my special thanks to Professor Chi Sunfek for being with us so late in the evening. In Singapore, it's close to midnight, I suppose. So thank you very much, ma'am, for giving us your tips and pearls in this oration webinar. Now I invite, before the closing remarks, Dr. Sanjay Gadre to add to what Dr. Arup and Dr. Chi Sunfek has discussed with Dr. Vasavda. A quick 2 or 3 minute discussion if you'd like to have. Dr. Gadre, sir.
Yeah. Can you hear me?
Yes, yes.
Oh, thank you very much, sir, for such an excellent oration. We have been listening to your talks and learning from you since last 30 years. And it has always been, something added. And I was waiting for, last 2 years, we didn't have any colloquium. So I was wondering what different you are doing this time and these last 2 years. And I was happy to know that you have this pearl about chronic closed angle glaucoma patients, where you put lens in the loop in the sulcus and the lens through both the capsules. So that's something that we learned from you today. And of course, you alluded to some of the basic principles that we must follow when we are doing practice. We should never forget that patient is at the heart of everything that we do, and be sympathetic to them. And we are not able to do too much of social service, but you serve the patients, and that is how you do social service through your profession. So you made that point very well. Okay. Nobody can teach you the surgical techniques because you are the best.
No.
And everybody has tried to learn from you over the years. And I just had a question about children below 2 years of age. With the modern lenses, the single piece lenses that we have, and which are so malleable. And because I saw some of the patients having 3-piece lens, say, placed in the sulcus and then optic capture done. I was just wondering that single-piece lenses also do equally well when they are put in the back. You have done a posterior capsular access and you have not done any anterior vitrectomy. Because, these two things are contradictory, that you don't do an anterior vitrectomy, but in 2 years old or less child, you do a vitrectomy, which is mostly anterior.
Yes.
And therefore, do you really need to do an anterior vitrectomy in these patients? And I think at this moment in time, what is your standard in these patients?
Yeah, I think, Sanjay, the fact is that the vitreous phase will act as a scaffold for the cells which will migrate in the middle, and it will become obscuring the visual axis. Not to the extent that you have to do vitrectomy and capsulectomy in this young every time, but the incidence is quite high, 3 out of 10 or something like that. So vitrectomy, I still do vitrectomy in children under 2 years if I cannot produce a capture. And when I say capture, I use haptics in the bag. So first the whole lens is put in the bag, and then the optic is pushed through the thing. So the entire complex is in the bag. But in that case, I don't do vitrectomy. But if I cannot achieve that, I still do it and recommend vitrectomy in children under 2 years. Whatever the other technique you do, I believe that vitrectomy, anti-vitrectomy, and I now do, if I have to do vitrectomy with the plan, I put the lens in the bag and put a pars plana trocar first thing before I begin the surgery, and then perform a pars plana capsulectomy, anti-vitrectomy. But whatever that is, I still think that anti-vitrectomy is important in children under 2 years if you are not able to capture. And capture is not an easy thing and not repeatable and predictable every time. So keep the vitrectomy ready to do it. But single piece or 3-piece, I think that I don't know whether it will change very much. It is the cells which will use that scaffold to proliferate. And sometimes it takes 6 months, a year, but generally in 1 or 2 years, it will show up. In many cases, not every time, but many, I think. So I still recommend. I'm sorry, but yeah.
Thank you, sir. I have a question of my own. You had talked about complications with and without intraocular lenses in children of 2 years of age or less. Did you study the amblyopia rates?
No. Well, I didn't discuss all that too much, but we had a primary objective was to safety, and in safety we said glaucoma, the cornea, the inflammation, and something else I forgot. And then we had a secondary observation of the visual development. And those who are aphakic, we paid them for contact lens in these bilateral. These were all bilateral, or glasses, whatever they, and we were supporting that. And the visual outcome was identical in both groups. But in reality, if you have an aphakia, visual outcome will not be that good. In a bilateral, it will be better. And it will be workable. Bilateral aphakia have a reasonable vision without contact lens also, and without regular spectacle, because bilaterality helps them. But the visual outcome was not superior with pseudophakia. Only thing what we found was in first year, the visual performance was better with pseudophakia. At the end of 5 years, and we had time pointed, at the end of 5 years, the visual outcome was comparable because we give them contact lenses.
Contact lenses.
We paid for it because it was a study. In reality, it may not work.
Right.
And that's what infant aphakia study found.
Right. Thank you very much.
Sir, one question. In case you are doing a surgery and there is a PCR and you have to do, say, optic capture, you're able to do an optic capture through the posterior capsule. So would there be a change in the IOL power?
Yes.
Case you...
Yeah. First of all, IOL type would be different. You have committed them a multifocal toric or a toric lens. You cannot put that. So you have to go for monofocal 3-piece lens, and the power would be half a diopter or 7.5 diopter more than what you put in. But I think the power is not a big issue. The real issue is the producing a safe eye and reduce the complications of CME, retinal, glaucoma, and so on. And that depends on how we handle the vitreous. So power point of view, yes, higher, obviously, but that is not as important as the other issues which these eyes can develop.
So we can expect more chances of CME in such eyes.
CME, glaucoma, inflammation, and so on. So we have to start. I give actually, if I do vitrectomy, I do intravitreal, steroids and or anterior chamber if I find. So we need to address right from the beginning.
Thank you very much. Before we close, I would invite Dr. C.R. Balda sir to give his closing remarks on what is an oration which is practically started by him, and no doubt in his honor too, but in the honor of Dr. R.N. Mathur, Dr. P.N. Nagpal, and Dr. C.R. Balda. Closing remarks from Balda sir, please.
Thank you very much, Dr. Porwal, for giving me the opportunity to give the closing remarks. Well, Dr. Abhay, you did a wonderful job. It was a wonderful lecture, trying to cover the vast field within a short time, and you dealt it with very, very well. Now, regarding Dr. Choi Soon Fei, Well, I had a chance to listen to her so many times in national and international webinars. She is a wonderful speaker. She also picked up very nice points about PCR and small eye management. And Dr. Arup Chakravarti, well, he is a wonderful speaker. I also had a chance to listen to him so many times in webinars, and I look forward to see him as the president of AIOS. And regarding Chi Sun Paik, I should say that Dr. Lalit Verma from Delhi has suggested that she should get honorary Indian citizenship because she is so often seen on the webinars on Indian continent. So these are the few remarks. And last but not least, I must thank the team of Rajkot Ophthalmic Society, Dr. Porwal, Dr. Suketu, Dr. Bhavisi, Dr. I may not be able to name all of them, but the teamwork has made this program a grand success. Once again, thank you all. Thank you very much, Abhay, Soon, and Dr. Arup. Thank you for sparing time for this major event. Thank you very much. Hope everybody, good night.
Thank you so much, sir, for your nice words. I think we have touched 9 o'clock. I don't want to hold people more on a Saturday evening. I invite our secretary, Dr. Suketu Bappal, to propose a vote of thanks.
So let me start with this pic. Gaurav bhai, can you post that picture? Yeah, let me start with this pic, which is well over 50-year-old, showing all three doyens, Dr. C.R. Balda, Dr. P.N. Nagpal, and Dr. R.N. Mathur from right to left, and they will be together forever in this oration. I thank not only these stalwarts, but their families too for giving us such peerless clinicians and teachers. I would like to thank Dr. Vasavada sir for accepting invitation to go despite being so busy, as well as showing keen interest in making this oration a success, not only this time, but for its future too. It was a truly oration par excellence, sir. Thank you very much. I would like to thank our guest expert, Dr. Chi Sun Fake and Dr. Arup Chakrabarti for giving their valuable time and pearls. I would like to thank Dr. P.N. Nagpal sir, Dr. C.R. Balda sir, and Mr. Alok Mathur for their valuable presence. Thank you all attendees for spending your valuable Saturday evening with us. I am told the attendance today is phenomenal. I would like to thank everyone in the Oration team and the ROS for making this event a grand success. Hoping to see you all back at next Oration in 2022. Thank you all.
I think 3 cheers for Rajkot Ophthalmic Society. Cheers.
Three cheers. Hip hip. Hooray.
Hooray.
Thank you, sir.
You deserve all the praise. You've done a commendable.
Thank you, sir.
Thank you, sir.
We started on time, we have ended on time, and it has been such a pleasure listening to you, sir, that we would like to listen to you again and again.
I'll come on the 10th oration, as I told you.
Done. Yes, that's a promise. We take it. Right?
We'll take the promise.
Thank you so much. Thank you, everybody. It's been.
Thank you. Bye.
Nice thing.
Thank you.
Good night.
God bless
Thank
you.
you.
God bless you.
Can we take a photograph of everyone, if whoever is present on screen?
Okay. Yeah. I don't
Sure.
know.
Yeah. Please don't go away just yet. A few more seconds. Gaurav bhai, can you put everybody on the screen, the speaker view?
Yes. Give me a minute.
Yes, now everyone will be hungry, yeah?
No, but this is important.
Yeah.
No, this is important. If you can get this everybody on the screen, or if you can take a shoot. I mean, we don't need to see them, but
Yeah.
if you manage it somehow with this technology, I don't know how they can do this, but
Yes.
Yeah, he did it.
Sir, I send you a copy. I take it.
Sorry?
He took it.
Yeah, I've taken it.
okay.
I have done it.
Right. Okay. Right, sir. Thank you.
Thank you, everyone.
Thank you.
Thank you, sir.
Thank you so
Thank you.
much.
Good night.
Yeah, bye, good night.
Thank you, everyone.